Yoga, you remember the other day we scrubbed in for an OT procedure? If I'm not mistaken, the rectosigmoid colon C.
You mean the 50-year-old Chinese woman?
Exactly. It was, if I'm not mistaken, a Hartmann's procedure, right? And remember we were sort of like examining her, and we managed to elicit some of cold clammy sensation. And what were your findings, sir?
Delayed capillary refill time, I noticed that as well.
Yes,
And she was tachypneic as well.
Tachypneic. And one of the most important thing is the BP, blood pressure also, right?
Yes.
How can I forget, Yoga? She was having low urine output.
Yes.
True? Yeah. And then when we moved on to the discussion, you were presenting the case, and when the consultant was actually approaching me for what's the management, then I took up the protocol, the care of the critically ill surgical patient based on that airway, breathing, circulation. Both of us were reading up on that, right? Remember before the presentation. And then when I said that for the circulation, we'll start him on fluids 1.5 liter. The consultant was, you understand, right? He wasn't really. I don't know what to say, but we followed protocol. That's why I was confused. Why the fluid resuscitation did not impress him?
Maybe I think we should go to our lecturers to get a better view of it.
Yeah, actually, I think the rudimentary concept behind fluid resuscitation, I think we haven't mastered.
Yes, true.
Okay, yeah. So I heard your case presentation. So, firstly, why do you think she's anuric, the patient?
Acute kidney injury, sir?
Acute kidney injury due to, is it pre-renal, renal, post-renal?
Pre-renal.
Pre-renal, okay. Probably dehydration. Any other cause?
Due to fluids, maybe?
Okay, dehydration, as you said. Okay. Could it be septic shock, anastomotic leak, you have to think? Okay, so was she showing any signs of peritonism? Okay, did you do an abdominal examination? You have to just bring that. But okay, but I thought it is too. So she was not septic. So what probably happened was post-op, there was no. Let's put it in a very laymannish term. Okay, so there was not enough blood to perfuse her organs. Okay? And so there was not enough blood volume, total volume, which was just going through all her organs, and that's what basically shock means. Shock means that circulatory failure, where you're not able to pump enough circulation to the tissues to meet the metabolic demand of your tissues. So you said that the consultant was not very happy with you giving fluid resuscitation. Okay, so why do you think the case was such?
I think there's a bigger picture that we are missing.
So have you heard about this term called fluid challenge?
Fluid challenge.
Okay.
I don't think so. No.
So fluid resuscitation is right, but again we have to go into something specific called fluid challenge. So if you were in your preclinical years, you would have definitely heard about the Starling Law.
Yes.
So what does this rule mean? Let's just recap a bit.
So the higher amount of preload will cause a higher amount of cardiac output.
Okay, so what is preload? Definition of preload.
Preload is the stretch of the ventricles to meet the demand.
Yeah, at the end of diastole. So the maximum dilatation, the maximum capacity of the ventricles to dilate at the end of diastole. Okay. So if you notice, the end diastolic volume. So the more the ventricle stretches, the more stronger it contracts, and therefore the cardiac output increases. So fluid challenge means you are giving a bolus, a sudden surge or influx of volume or fluids into your body. So if you just generally put a cannula and you put drips, it's going to be a very slow resuscitation. Kidney is failing, right? I need to make sure that the blood volume is exaggerated to a point where the circulating volume is re-established, and the amount of blood which is perfusing through the kidneys, delivering in oxygen, is good. So fluid challenge is done by giving 250 milliliters or 500 milliliters of crystalloids bolus as fast as you can, or you can follow 10 to 20 milliliters per kg. But the idea is you're giving a huge volume of
sudden influx of
Exactly.
volume.
So when you put a sudden influx, where does the volume, the crystalloids, let's say there's some fluid, you are putting it through your catheter, cannula. So where does it eventually enter? It's entering your blood.
Heart.
It increases the blood volume. Yes. Which part of the heart?
Definitely the left ventricle.
Left ventricle, right? So it'll enter the left ventricle. What does it do to the end diastolic volume?
Increases the volume.
So what will happen? The cardiac output will increase.
Yes.
Because it stretches.
Yes. So if you give slow fluid resuscitation, if you're just putting a drip and waiting for the drip to just drop, you're not stretching the diastoles.
Yes.
When you give fluid challenge, you're giving a sudden surge and you suddenly stretch the the ventricles to a large extent, and therefore
Improves the cardiac output.
the cardiac output increases. So the heart contractility of the myocardium increases. Cardiac output means the amount of blood which is exiting the aorta increases.
Yes.
The cardiac output increases, and the perfusion, the volume, that huge surge of volume of blood which goes out of the heart, perfuses the organs rapidly. Okay, it's a faster, it's actual resuscitation.
That's how
And
we address the hypovolemic shock.
yes, and number two, fluid challenge is also helpful to assess the cardiac function. So it's both diagnostic and therapeutic. That's why he was probably not happy, because here you have to probably give fluid challenge. So if you understand this whole Frank-Starling law, you can understand a lot of principles in surgical management. For example, let's say someone has aortic stenosis. Aortic stenosis means there's basically, so it's a rough image, okay? So whatever blood which is being supplied to your organ comes from the pumping, the contraction of the left ventricle, which pushes the blood into the
Aorta.
aorta, and the aorta gives a lot of other branches
Yeah,
which okay, supplies the entire. So this is what the example we saw is in a case of post surgery. So at times there are a lot of other morbidities which will be easily understood by this mechanism. For example, aortic stenosis. So as you age, when you age, sometimes lipid accumulation will happen and fibrosis will happen, and this will cause aortic sclerosis. Aortic sclerosis, so this, let's say this is the ascending aorta. Okay, sclerosis will calcify and it will narrow, yes, and it will cause stenosis. The aorta's diameter, the lumen diameter will decrease. So what will happen then?
So
Blood
the
flow
increase
will be-
cause rupture.
Anything else? What
Mismatch.
is our concern?
Mismatch.
So if he's going for surgery, okay, I need adequate cardiac output.
So there will be mismatch between the supply and demand of blood.
Yeah, but why? Because the cardiac output is fixed in aortic sclerosis. So let's say the dimension of the diameter of the aorta is limited. There's only a limited amount of blood that can go through it, no matter how hard the heart
yes.
pumps. Isn't that right?
Yeah.
So in surgery, when someone is butchering you, the need for adequate cardiac output increases because you're losing blood. You are in a stress situation. Okay, yeah, your body is producing all the stress hormones, serotonin, endocrine hormones, and you know some of the anesthetic drugs themselves will
Stress on the heart.
okay, and some of the anesthetic drugs will require a higher cardiac output because the general afterload would have decreased.
Yeah.
So during surgery, the demand for the increased cardiac output is always increased. So that is why it's important if someone is aged, they have aortic sclerosis, stenosis, you want to measure. If it's very small, like 1 cm or something, then they are not fit for surgery. Okay, and any other causes, let's say you have some
Comorbidities.
yeah, like rheumatic fever, for example. Okay, rheumatic fever, or let's say, okay, let's bring the same aortic sclerosis here. So what happens when you have a limited cardiac output here? So there will be backflow of blood. Okay, there will be more burden on the left ventricle. The left ventricle will start contracting more frequently and it will get hypertrophic. So when the left ventricle gets hypertrophic, the chamber size will decrease. The chamber size will decrease. So there will be backflow of blood,
Pulmonary congestion,
pulmonary hypertension will increase, and eventually this left ventricle will
be incompetent.
Yes, and it will go to left ventricular failure and eventually death. You'll get MI and death. Because you need to know what will happen when you don't have enough cardiac output.
So doctor, in a case of we are giving CPR for example, so if what happens if the we are giving CPR and the CPR the compression is too fast, the cardiac compression is too fast, which I personally feel it will decrease the effectiveness of the CPR because the preload will be less. Is it
exactly right? That is why there's a
100 to
there's a
130.
yes, and see all these protocols which is coming. Can you see it comes from the basic understanding of physiology and preclinical? So if you actually have a good understanding,
We understand what's happening.
you don't have to read. Yes, so exactly, it's because you need time to allow
for a
the
ventricular filling.
ventricular filling. If you just keep, that is equivalent to increasing the heart rate without any output, right? And importantly, you need to know you need enough blood to go throughout our aorta. So why does reduced cardiac output bring disadvantage? What is the first branch of the ascending aorta? What is the branches of the ascending aorta?
Subclavian, carotid, and
Right carotid.
Right carotid, yeah.
So where does the carotid arteries go? They supply
to
the
the head, brain, to the head and neck.
right coronary artery.
Okay.
Ascending. So you will have the right coronary artery branching out. So why does a right coronary artery supply? Heart. So it actually supplies heart. So if you have low cardiac output, if you don't have enough blood going to the aorta, remember the blood flowing through the coronary artery, which eventually gives blood supply. The heart itself will be insufficient. That will lead to MI, myocardial infarction. Ischemic heart disease. So this is why it's so important, this principle, to know that because patient might not have any risk factors just by age, senile aortic sclerosis, stenosis, you're sending for op, the demand for cardiac output increases, but your blood, your heart cannot pump against the, it cannot stretch a calcified narrow lumen. So it will overwork the left ventricle, the demand for oxygen will increase, and the right coronary artery, which branches from the ascending aorta, cannot supply it with the increasing oxygen demand. Left ventricular failure, reduced left compliance,
congestion, pulmonary edema,
and MI.
So doctor, what if due to the stress to the stenotic aorta, so if constant stress is applied there, the complications are?
As I just said that, so your heart will, your left ventricle will always try to pump to give a higher cardiac output. But remember, the more it's just trying to pump against a fixed narrow blood vessel.
Okay.
So if the cardiac output here is fixed, if the demand is, let's say XXY, the output is only XX. Okay, or let's say it's the demand is YYY, your output is only Y. Okay, just giving an arbitrary equivalent. Okay, and remember the ascending aorta, the branch is right carotid. So the first complication is the heart itself will be, the heart is unable to pump blood to supply itself. So you'll get patients will get MI easily. Okay, that is the. So that's why it's very important not to send. Okay, pre-op assessment is very important, and I say you can apply this in any cardiac situation. Post MI, okay, post MI there will be an infarct. Okay, there may be a fibrotic tissue. Apply the same thing. It's all about cardiac output.
Post MI.
Yes.
Restless syndrome also.
Yes. Okay. And even in normal patients, let's bring this whole concept. Let's say you are not having any comorbidity. The formula of your cardiac output is heart rate and stroke volume. The amount of volume which is exiting and the heart rate. That is why when you lose fluid,
compensated by increased heart rate.
So stroke volume, when the total volume in your body decreases, your body will increase the heart rate. How? Because you have mechanoreceptors at the arch of aorta.
Okay.
So the amount of blood, the cardiac output is the amount of blood. So the amount of pressure which is pushing out the aortic arch of aorta, the baroreceptors, mechanoreceptors. Okay, they are sinus of Herring, supplied by sinus of Herring. They will be stretched less. So the firing rate will increase and it will increase the heart rate.
So basically, it's just a sensor.
Yeah, it's a sensor, exactly. So when you refill the patient fluid, when the stroke volume increases, your heart rate will come back to normal. So that's why fluid resuscitation.
So we don't have to give any to decrease the heart rate, any intervention for the heart rate. We don't have to give beta blockers or anything for that. We have to treat the root cause in order to bring everything
exactly. But let's say in the case of sepsis, okay, where stroke volume, it doesn't respond to resuscitation, you need to increase the heart rate.
Yeah.
That's when they give you inotropes.
Inotropes, yes.
They'll give you all the inotropes to increase the heart rate. Yes.
So the heart rate is a compensatory mechanism
Yes.
to the decrease in cardiac output.
Yes. Cardiac output is equivalent, it's parallel to blood pressure. And coming back, so how does fluid work? So let's say you talk about resuscitation. What made you think of resuscitation in this patient of post-op dehydrative AKI?
We are replacing the fluid which is lost.
So how does fluid? So there are many types of fluid, right? You're thinking about crystalloids, colloids. So
Yeah.
how? Any idea on how they work? Why can't you just make the patient drink water if they are tolerating orally? Right?
Yes.
Makes sense, right?
Because
So after all, dehydration. So why can't I just drink water? Why can't I just gulp
because I
water?
think there's something called like intracellular fluid,
Yes.
extracellular vascular fluid.
So to understand that, we go back to our Tarika.
Physiology.
Physiology.
Year one.
Where did we learn this? No, I learned this in school, right? When I was
Standard
school,
science.
Standard 6, right?
Form 1.
From what? Standard
Form
6
1.
class.
I learned in Form 1. I learned in Form 1, osmosis. Oh, you learned in Standard 6.
No, we all learn Standard 6.
I learned in Form 1. Okay, so explain this. You are closer to Standard 6 than I am.
So it's basically whenever we see osmosis, it's related pertaining to water. So whenever there's a higher concentration of volume here, so let's just say this is solute. So this is higher concentration of solutes, and here there's a lesser concentration of solute. So the water would move to the place where there's higher concentration of solutes to compensate.
Okay.
So that's why it's meant by higher to lower.
So it's just like, let's say I have a beaker without salt, a water without salt, and some water with salt. In order to dilute this, the water will move out from
Yeah.
it. It's just dilution.
So from hypotonic,
You'll go to a
hyper.
hypertonic. So that's the same. So remember, whatever fluids you're putting it in, it's inside the veins. It's
Yeah.
basically blood vessels, veins, and then it'll go to the heart, and eventually, right?
To the whole body.
So there are several spaces that we call. So this is the intravascular
Fluid.
compartment. Intravascular means inside the vessels, basically your blood.
Compartment.
Then your blood, your body doesn't just have blood vessels. What is outside the blood vessels? Extracellular compartment. So, and you have your cells. These are your cells. So this is what basically your blood is passing through. Like it's a passage which carries all the oxygen so that they can perfuse and enter and give oxygen to the cells so that they metabolize and they function. Okay, so this is like the carrier which gives the ration to all your cells which are functioning.
Providing nutrition to the cells.
Yeah, so you need enough volume here to carry whatever oxygen. and-
Perfuse the organs.
Yeah. Imagine if this is just a vessel but it's empty. What is going to happen?
Yeah.
Right? So the idea is to make sure whenever we talk about fluid resuscitation, it's always pertaining to the intravascular fluid. So we just play that game of here. Okay, so this is intracellular fluid, extracellular fluid, intravascular compartment. Okay, so we have some names. This is the first space. Intracellular fluid is called the first space. Extracellular fluid is called the second space. Okay, so when you put crystalloids means they have some electrolytes, composition of electrolytes which resemble in concentration, they are very similar to the extracellular fluid.
Okay, I understand.
So what happens when you put in crystalloids into the blood vessels?
The rate of exchange will be the same.
Exactly. So the amount of water leaving and entering is the same because concentration is same. That is what they okay. So that is what we mean by isotonic fluid.
Isotonic.
Okay, whatever you're drinking is 100 plus.
Come again. The isotonic means the water flow between the intravascular compartment and extravascular compartment will be the same.
Yes, and or intracellular compartment will be the same.
Will be the same.
Yes, exactly. Okay, intracellular compartment is a subset of extracellular. Like it's outside the vessels. Basically, it's anything outside the blood vessels. So this is the same concept which applies to the 100 plus, etc. Because let's say if you give a hypotonic fluid, a fluid without any electrolytes, distilled water, pure distilled water, what will happen here?
It will move out.
It will move out to dilute the concentrated stuff here because your extracellular fluid is filled with cells which have a lot of other cellular components. They are high solute level.
think that's where the hydrostatic forces comes in.
Yeah.
Because inside the intravascular compartment, there's more volume of blood. Sorry, basically there's more volume, and so the hydrostatic, because water controls hydrostatic forces, so that's when it causes water to leave out of the
Yes.
intravascular compartment.
Yes,
If
exactly.
I'm not mistaken.
Exactly. So not all forms of fluid intake actually rehydrates. If you're taking some fluid which is very dilute, it's going to go out of your vessels anyway.
Causing edema from sometimes?
Exactly, edema, right?
Yeah.
So you can be dehydrated and have edema at the same time. Because edema is collection of fluid at extracellular fluid level. Okay, it's an extracellular level.
Particularly the interstitium, one of the compartments, one of the
interstitium. Yes. And how does colloids work? What are colloids?
I think colloids is
Has albumin.
Heavy molecules, basically.
Heavy.
Albumin, starch. So it's very hypertonic, it's very concentrated,
Solutes.
it's very solute rich. So what happens when you put water filled with heavy molecules here?
If the concentration is higher than what is outside, so it will pull the water.
Yes, high concentration. So it will pull all the water from the from the intracellular compartment inside, and it will increase the
Blood volume.
So you can see crystalloid and colloids at the end of the day, it's all about increasing the
Intravascular.
Okay, that's why they are sometimes called, like crystalloids are called plasma expanders. They're called volume expanders.
Understood.
They expand the intravascular volume. You get
I
it?
think one of the components that applies to us and also first year or second year students is like what you said, Doctor. Colloid, it contains albumin. So albumin, as we all know, is internationally known as the oncotic pressure. It maintains the oncotic pressure. So this is what it's meant by oncotic pressure.
Yes.
Because when there's increased oncotic pressure, it pulls water.
It sucks out all the water from the intracellular into the cellular compartment into the. So it's not like you are actually putting in isotonic volume. In colloids, you are just you're pulling all the water inside the cells into your blood vessels so that the blood vessels has higher. Again, for the same purpose of perfusion, you want to make sure that there's adequate volume which is reaching all the cells.
Another clinical relevance would be nephrotic syndrome. One of the triads includes hypoalbuminemia. So it causes edema because the blood vessel has lost the ability to pull water in
Because it lacks albumin. It has low protein.
Low protein,
Okay.
The effacement of the podocytes.
Also-
The leaky
also will cause proteinuria.
Yeah, proteinuria.
That's okay.
And one of the clinical relevance I thought of.
Exactly.
I think now when you explain, it further consolidates why it happens. Okay, Doctor.
Can you understand why hypovolemic shock happens in burns? Why is that? So burn, we talk about third space.
Yeah.
So this is like first space, second space. So what is third space? So one of the complications in a burn victim is always hypovolemic shock. They lose a lot of fluid. But why? You're just burning them, right?
Yeah.
How does it cause? They're not
Leaky, something also.
So burn will actually, it will destroy the layer, so it will increase the permeability of the capillaries.
Understood.
So what will happen is the solutes which are already inside the blood will leak out. Yeah, it will leak out. So all the proteins, albumin, it's going to leak out. So what happens when all the heavy molecules inside the blood vessels leak out of the blood vessel?
So hypovolemia, because decreased cardiac output and all happens
Yeah.
because
So the blood cannot pull fluid from outside, right?
Because like what you said, the heavy molecules goes out, ability to hold water in
Exactly.
reduces.
It reduces.
so it can cause edema as well.
Yeah.
It's possible, and it will also cause. That's what we mean by augmentation of the third space. So you won't be able to contain fluid inside here.
So that's why hypovolemia.
Yes, and
Okay.
and you will third space means spaces where fluids don't usually occur. Peritoneal cavity, abdominal cavity. For example, ascites. It's an example of accumulation in the third space.
Pulmonary edema.
Yes,
One of the
third space. So third space is areas where cavities where fluids don't usually occur. This is an example. So that's what they always mean by augmentation of the third space.
It makes sense, Doctor. Completely. I mean, it's gotten an enlightenment. Thank you, Doctor.
Now, we'll continue about shock a bit. So have you heard about shock? So what do we mean by shock?
Shock is mismatch basically.
Prashant's movie.
No. Does it mean mismatch or
Sudden change in the body.
So
mismatch
shock.
between supply and demand?
You already, yes, exactly.
Supply.
So your blood is circulatory failure where, despite the resuscitation, you're not able to pump circulation, perfusion to all the cells. Lack of perfusion, so the metabolic demand of the cells are not met. So there are many types of shock. So what are the examples of shock that you know?
We've got
Neurogenic shock.
Yes.
It comes under obstructive shock, and we've got we've got cardiogenic.
Okay.
Anaphylaxis.
Okay, so let's talk about something like hypovolemic shock or septic shock.
Distributive. Is it?
Okay, let's talk about hypovolemic shock. First, hypovolemic. So hypovolemic means perfusion is lacking simply because there's no blood inside, there's no volume inside the intravascular compartment. So what will happen? Your stroke volume will decrease, heart rate will increase, and cardiac output equates to BP. Cardiac is increasing because it cannot meet a cardiac. So they'll have usually low BP, high heart rate. And you have to know a new term, systemic vascular resistance.
I see.
And what is systemic vascular resistance?
It's the force opposing in the vascular compartment.
Yeah.
Is it?
Yeah.
So let's say shock means I have a hose pipe here. There's plants there. There are plants there.
Close the loop.
Water is actually flowing, but it's not perfusing the plants there. What must I do to make sure the water hits the plant? Squeeze it. That's exactly what we mean by vasoconstriction. So when cardiac output is low, when perfusion is low, your body will go into stress response. It will produce cortisol. Where does cortisol gets produced? Zona fasciculata in the adrenal cortex. Catecholamines from the adrenal medulla. All these
This
guys,
is where the RAS system is
RAS,
activated.
angiotensin.
Efferent arterioles constricted.
Yes, all these will constrict to increase the pressure so that the perfusion increases.
Understood, doctor.
So that is also why in septic shock or any form of shock where you want to increase the blood pressure, you want to give inotropes. If your body cannot respond naturally, you artificially give inotropes to increase the contractility. We increase the systemic vascular resistance.
Adrenaline, all those.
Yes, adrenaline, noradrenaline, exactly.
Understood.
And in septic shock, you don't get increased systemic vascular resistance because septic shock with all infection, they produce a lot of bradykinins, mediators which will actually disable the vessels from constricting. So you'll get vasodilation. So imagine I have a hose here, plants there, water is coming, you're putting fluids into me. Water is flowing, but it's just leaking to barely a few centimeters away from me.
Still not able to perfuse.
Because your body cannot vasoconstrict.
So technically they are permeable.
Basically, you don't have the pressure to shoot the water.
Yes, okay.
So you have to give them inotropes, etc. And basically in septic shock, you notice that the systemic vascular resistance is actually low. And that is why in septic shock, the hands will be warm.
Because
It's vasodilated.
Dilated.
So vasodilated. So you're just pouring out. You don't have the pressure to shoot the water. Okay.
but there is output.
There is some output, but there's
pressure.
BP is still low.
So doctor, how do we actually treat
Inotropes cause so same thing. ABCDE.
I think
There's
the septic shock, we have
sepsis,
to address the cause of the septicemia.
septicemia, broad spectrum. You have to consult your microbiologist.
If
Follow
usually
your.
it has an underlying pathology, like example pneummonia.
Yeah.
Rarely it causes,
But that's one. First, you have to reset.
Yeah.
Importantly, oxygenation.
Yes.
You want to give oxygen because whatever blood that you're having here, it needs to deliver oxygen.
Yes, correct.
Put on oxygen. Make sure that you follow the ABCDE protocol. Yeah, make sure that they might need ventilation. You want to maybe consult your anesthesiologist
Care of
for
the critically surgical patient.
intubation. You want to maybe put invasive ventilators, and you want to insert catheter, urinary catheter, monitor urine output. Okay, you have to do a lot of. There's something called sepsis 6. So you have to take a culture from the source of infection, right? Okay, it's multi-dimensional. Okay, and you have other forms of distributive. These are all called distributive shock. Whenever you see low systemic vascular resistance, vasodilation, you think about distributive shock.
Anaphylactic, septic.
Yes, it could be also epidural.
Oh.
So when you want to give epidural, sometimes if you give a very high epidural block,
Okay.
you will accidentally affect the systemic cardio accelerators.
Okay.
So your heart won't be able to hit fast. So that's when you give chronotrope. Chronotrope increases the
Okay.
heart rate.
Yeah.
So just remember just
Chronotrope, yeah.
these ideas. And just now earlier when when we were seeing the case, we said tachypnea. Okay, blood pressure was decreasing. You guys mentioned that there was clammy peripheries, CRT was increased, BP was dropping, and tachypnea. So instead of which would be a better cardiac indicator? Tachypnea or tachycardia?
Tachycardia.
Okay, why?
Because
I mean, tachypnea, it is a sign of hypovolemic shock, not denying.
Tachycardia.
But anything else? Why not?
Because the heart rate is more conclusive to a hypovolemic shock
Yes.
compared to tachypnea.
So tachypnea can also, remember always, tachypnea can come in several other conditions. For example, acute respiratory distress syndrome. It's a common sequelae of surgery. It can come in pain, simple pain. You get tachypneic when you're pain because there's an increased
even in
sympathetic
children,
drive.
Even in children for different pathology like foreign body aspiration, even things like that, which isn't relevant. to-
Yes, so tachypnea is not very specific.
Very, yes.
Tachycardia is a little bit more,
Autonomic
it's
sign.
more specific because it's internal. Because heart respiratory rate, even general pain, as long as sympathetic drive gets pumped, you get tachypnea.